This video is about management and outcome of an unfavorable macular hole. So, macular holes are idiopathic diseases which affect the central portion of the retina, where because of the splitting of the retinal layers, there occurs a hole formation right at the fovea and causes significant diminution of vision and a central scotoma. So, this is the patient in which the photograph of the fundus shows a small hole, and if we look at the OCT image, you will find there's a hole which has an unfavorable configuration. So holes which are rising high are usually considered better, and there are a few indexes, and here in this video we can see the macular hole index of this particular hole was 0.76, and a macular hole index of more than 0.5 is considered favorable. However, diameter hole index and the traction hole index both were unfavorable. A diameter hole index of less than 0.5 is considered better, and tractional hole index for more than 1.4 is considered better. And more than that, we can see the configuration of the hole. It is very flat with sloping edges rather than rising edges, and these kind of holes, they respond very poorly to the surgery. So this was a surgery in which, and if the patient is phakic, we usually combine it with cataract surgery, because invariably the installation of gas in the vitreous cavity will cause cataract formation. The cataract surgery has been done with implantation of a foldable posterior chamber IOL, and now we are proceeding for pars plana vitrectomy. So placing the trocars through a transconjunctival route. So these are very small gauge trocar cannula. This is 23 gauge, which will leave behind a self-sealing wound which doesn't need to be sutured. And I usually prefer to use a chandelier which provides a nice wide illumination, and along with a wide angle viewing system, the view is excellent. The first thing to be created is the PVD, so that the retinal surface is devoid of any vitreous adhesions, and you can work directly on the retinal surface, which needs to be stained with vital dyes. So one of the dye, which is brilliant blue dye, is instilled after exchanging the fluid with air, so that the dye is in good contact with the retina. Once the dye has stained the internal limiting membrane, one starts peeling it after creating a flap. So here we can see a flap has been created and the ILM peel has started. So this portion of the video is heavily edited, because ILM peel is a very delicate job and it requires a lot of patience and tries so as to create a flap and catch hold of the edge of the ILM so as to safely peel it away from the retinal surface. Invariably, there are some adhesions on the retinal surface which will cause some amount of very small petechial bleeds, which is of no consequence later on. So the aim is to not to touch or mechanically handle the retina and proceed with removal of this internal limiting membrane. Now the rationale behind removing the internal limiting membrane is that this usually is the surface where the tangential forces are acting. So once you remove the ILM, the tangential forces which are pulling the retina and splitting it are also wiped away with the removal of the ILM. So that is why it is considered important to remove the ILM. So ILM has been peeled away now, and then the time comes to change the fluid with the gas. So air has been instilled after removing the fluid from the vitreous cavity and removing the trocar cannula from the sclerostomies, and these are self-sealing sclerostomies, so there's no need to suture them. They will simply seal on their own, provided some amount of massage and manipulation is done on the surface. Once this has been done, C3F8 gas has been instilled, and this is the picture at 15 days, and we can see the hole has closed nicely, and this is known as type 1 closure. And on closer inspection, we can also see that although the hole has closed, but still the photoreceptor layer is disrupted. And that is the reason why this patient didn't have any very good visual gain. And the final visual acuity which improved was from 624 to 618. Thank you.